This is a pretty informal briefing on the essential element of public health pertaining to the pandemic. So I'm the director of the CCHN. I also teach at the Harvard School of Public Health. I teach global health. And for me, it's a connection between two domains that I have at heart, that is humanitarian negotiation, on which I've been working now for 20 years, as well as public health as this meeting point between science and public policy, and to see how we as frontline humanitarian negotiator can use public health in a situation like the response to the COVID-19 pandemic. So the purpose of the session here is really to enter into a negotiation on public health, a negotiation on the access in the pandemic, and to see what can we draw from the public health domain in the arguments or in the planning of a negotiation. We'll be more specifically discussing the role of humanitarian negotiation and negotiator in the implementation of a public health response. And then it sets the ground for the simulation that we'll be working on with Will and Brett. Do not hesitate. So it's a briefing, and we're a small group. Do not hesitate to raise your hand, ask a question. Will follow the raised hands. I do not see the raised hand when I do the presentation, so don't hesitate to raise your hand, and then Will simply interrupt and give you the floor. Okay, so if you have any questions, need for clarification, or point to discuss. All right. So we're starting with a concept. What is public health? Public health is a vast domain of interconnected scientific fields, about disease prevention, about, food security, about health promotion, surveillance, risk management, and so on. And it is this combination of every scientific field that contributes to improve the health outcomes of a population. In the 20th century, life expectancy in the world, went for about 35 years old 150 years ago to over 70 years old nowadays. Not so much because there was a lot of discovery in terms of cure for diseases, but mostly because of the development of public health and public health measures. Things that we don't, that we take for granted: washing hands, cleaning teeth, water management in cities, urbanism, has all been informed by public health discovery of how can we maintain an environment that is that allows the improvement of the health of the population as a whole. So as compared to health services, which is really about the health of individuals and community, public health deals with the health of population. And this large number of scientific domains converge into informing public policies that will affect the health of individual communities, nations, and then globally, as we see in the current pandemic. So it brings science and all the objective assessment and evidence-based research into government policy. And when we say government policy, we also say government politics. That is, it creates a competing agenda to economic recovery, social development, and other domains that may be in tension with public health. The second point we want to clarify is this notion of pandemic. What is a pandemic as compared to what is an epidemic? So an epidemic is a spreading of infectious disease in a specific community or a region that will create an excess morbidity, that's people sick, or mortality, that's people dying. Okay, so it is an infectious disease, it's contagious, but it affects a specific community or region. Now, a pandemic is different at two levels. One, it is the spreading of a new infectious disease across many countries. That's the second element. So it involves a large number of population who have no pre-existing immunity. Okay, this is why it becomes a pandemic, because there's very few people who are immune from this new infectious disease. In the case of COVID-19, the disease was not moving around people before, we estimate, November, December. This is what happened. It started to be transmitted among people, and people don't have immunity because it's a new disease and it's spreading across the world very quickly. Just to compare this pandemic, that is a spectrum of recent pandemic that took place that had a global dimension. And we say COVID-19 is currently at 373,000 deaths. Compared to swine flu, it's just 200,000. SARS, only 770 people died. Ebola in 2014, 2016 was 11,000 deaths. So we are in a range of serious impact on the health of population at the global level, as it's now reaching, and it's far from being over, reaching almost 400,000 deaths. Now, the question is, how vulnerable the population can be to an infectious disease? Because the point that is important, we as humanitarians dealing with the pandemic, is we are not dealing with the pandemic as a disease. The disease in itself is not particularly serious. I mean, SARS has a death mortality of 20%. In the case of COVID-19, we are between 2 and 5%. It may be a bit higher for certain age range. But the point of the pandemic is the contagious aspect of the disease, how fast it's spread, and how many people can be infected. So the vulnerability of the population depends, therefore, on the number of people who can be infected, those who are infected, and the connection between these two groups. So the virus, to spread, the virus needs access to people who are not yet infected, evidently, and who are not yet immune. The most effective carrier of the disease are people who are infected but don't show any symptoms. This is what we call asymptomatic people. That means they can move around and infecting more people, while those who are sick, well, you can see they are sick and they tend not to move much. So a pandemic, they need the crucial role of the spreader of the infection. It's people who have no symptoms to have connection, contact, physical contact, or to leave the virus where they go with people who are not infected yet. Now, you may have heard the concept of herd immunity. Well, herd immunity is when there's not enough people to be infected that are not immune yet. So herd immunity is that there are people who are not infected yet, but there are not enough of them for the disease to spread and the infection dies out. So it means a certain percentage of the population have been either vaccinated or have been already infected but survived the disease. Now, a point for, country like Cameroon or any other countries is how fast an infection disease can spread. This is what we call the famous R number. The R number means the number of people in average that will be infected by someone else who has the disease. If the R number is 1, it means for every person who has the disease, they infect in average one other person. It means that the disease is spreading, but it's not spreading in an exponential manner. If the R is infecting less than one person, that is the R, we say between 0 and 1, the disease is not spreading, it's in fact shrinking. However, if we have a R that is around 2, well, every infected person is spreading 2 people in this, and every new people spread to 2 more. And this is how you see the exponential character of the curve we've seen recently. You see the curve you have there, the red one, starting from December 19 to February, where you may have 227,000. This is R3.1, R 2.6 is in the middle, and R 1.9 is much lower. So the movement from R1, 2, and 3 is really exponential, meaning the number of persons that are being infected by one individual, and depends evidently on the social and natural environment and the behavior of people. This is where the confinement policy come in. Why we have confinement policies? Because we're trying to get the R number down, to get the curves going from red to blue to violet, to get the curve down so we can bring the disease under control. Here you have the curve for Cameroon. The curve for Cameroon is currently somewhere around 1 and 2. There's an increasing number of people being infected, and this increase shows that it is moving toward an exponential curve, meaning the disease is spreading quickly and may end up infecting a lot of people. Over the coming 2 to 3 weeks, it may even double every 2 to 3 weeks. Now, some of you may think, well, how does it matter if there's not enough testing? Now, it's a point that is important here. You don't need to test everyone to know how many people are infected. You need to have a representative sample and to follow that sample over time. In that case, we may assume the sample is people who get to a certain number of hospitals where there is testing capability. This is where the number comes from in terms of increase of positive test results, right? If you keep the same sample going, the same method of testing, it may in fact represent the curve of a much larger number of people, but with the similar curve going up in a country. I thought it's interesting to look at other R number to other infectious disease, just to see how it compares. You take measles, for example, it has an R number of 12 to 18. It means it's extremely contagious, meaning when measles starts, it's simply like fire and hay. You have other disease like smallpox and polio has R number of 5 to 7. In the case of the influenza, SARS, or the influenza pandemic of 1918, and as well of COVID-19, we have a R between 2 and 3. And that's somehow where we are. That's the natural level of contagion of a disease. And this is what governments are trying to bring down by having social distancing and confinement measures. So how do we stop a communicable disease from spreading? Well, it's to limit contact. Bring that R number now down. Once you have someone that has been infected, try to trace those who were exposed to this individual and limit the spreading of what we call super spreader events, church, football stadium, people moving around, potentially communicating the disease to many other people. These are called the super spreader. And to protect those most vulnerable to the infection, in that case, the elderly and those who have other disease. Now, some ask, well, how does it end? Well, as the logic is, it ends ultimately when there is not enough people to infect, meaning people are immune to the disease. Okay. The slowing down of the outbreak depends on the ability to isolate people who are infected than those who are not infected by tracing and testing. The outbreak tend to evolve by wave, and that's an important point for the future in countries like Cameroon and many others, that the wave we currently have is by all means what we call the first wave. A disease in a population propagates like any storm, any movement, because it has this wave function, this wave behaviors. There are different scenarios. This is coming from a world-renowned group of researchers in the United States who do scenarios regarding the development of pandemic. And the three scenarios is one, peak and valley, which is simply goes on, okay, every 3 months, 6 months, there's a new wave until we reach an immunity of the population. There's a second scenario of a much bigger second wave. This is the case of the influenza pandemic of 1918, the Spanish flu that is called, where the second wave was much more strong than the first wave. Or you have a scenario 3, which is a slow burn, much smaller wave follow the first one. Now, there's no indication currently which of the scenario the world will face, but all experts agree that unless and until there's a global vaccination campaign with a vaccine that is effective to prevent a second wave, there will be a second wave, as in the case of other pandemic. So the second wave and third wave will go on until it reaches 60 to 70% of the population that will become immune because they have been either infected and recovered, or they have been receiving a vaccination. This is what we call the herd immunity. Now, who is responsible for containing a pandemic? Well, everyone. Every individual is responsible, being infected or not infected. Again, we saw the infection needs non-infected people. The spreading depends on the accessibility for people who are not sick. This is why there's a lot of responsibility to everyone who is not sick to be careful vis-a-vis asymptomatic people who may be infected and they don't even know. In the case of the SARS, for example, people would become infectious only after getting visibly sick. That makes easier to contain the pandemic. In the case of COVID-19, people become visibly sick 5 to 7 days after being infected and being infectious, which open a window of infecting a lot of people. So the responsibility requires, therefore, the imposition of a national plan where you have a whole population being, their contact being regulated. It needs to be informed by facts and experience based on science. And for negotiators, it's an important point. If you negotiate regarding public health measure, you need to know what you're talking about. Therefore, you need to have experts or people who are knowledgeable from WHO, from MSF, other organizations who can help you understand the situation. And the role of public authorities, municipalities, head of communities is central in this effort. And more local, the better, because you need trust of the population. Why should they social distance? Because we trust the authorities in bringing these measures. So the strategic priorities of a government, of a municipality, of an organization working in such environment is to have a strategy. The strategy is how are we going to carry the cost of containment, confinement, and restriction for a benefit that will come later on. That's what a strategy is about. How to mitigate the health consequences of the disease for those who will fall sick. How to sustain the health infrastructure and mitigating the impact on the economy. And that's a central point in Africa, that you cannot contain the pandemic with measures will have much more of a burden in terms of economy and the functioning of society. How you distribute capability with local authorities, communities, and health providers who are at the level of the population where there is trust, and develop partnership with charitable actors, while always emphasize that it is a public authority responsibility to coordinate local action. Now, what about us, the humanitarian? Well, first of all, we need to recognize that our humanitarian model just says we're not doing development, we're not doing security, we're not doing politics, needs to be looked at. Of course, we're not political actor. Of course, we're not into development. But the pandemic doesn't know any difference between humanitarian and development. Therefore, part of our activities needs to support local and national authorities in their response, even in a conflict environment. We need to understand the critical interdependencies in the planning of operation. In terms of norms, yes, we have humanitarian principles and norms. So we need to be ethical and strategic to understand the public health and public policy dynamics at play. Recognize that there are infrastructure and societal needs, not only population. If you want to respond to a pandemic, it's not only about humanitarian assistance, it's also about strengthening the health infrastructure of the locality, of the community, and contribute to the design of a national response. But overall, and this is what we're good at, is to regain control over the crisis environment, to see that there is a weight between risk and benefit, and for the beneficiaries and for the staff. And more important, avoid becoming a spreader. That is, humanitarian professionals, as they move within refugee camps, migration population, visit prisons, visit communities, they are potentially super spreader. So it's vital that humanitarian professionals take measures to prevent the spreading of the disease through their action. So to sum up, as a humanitarian negotiator, you need to engage with public health authorities and you need to know what you're talking about. Promote the respect of principles, certainly, but be ready to address potential areas of friction between humanitarian imperative and public policies. And in that sense, navigate the tension. So I'll finish here with a table for those who remember the typology, that there are three types of negotiation as you engage in the response to COVID-19. There's the political value-based negotiation, right? Which is, yes, the humanitarian positions about humanity, impartiality, neutrality, and independence. However, we should not assume that public health is humanitarian. Public health has its own principle. First one is efficiency of the response. Equity, we're here to protect all the population, not the most vulnerable, right? And it needs to be integrated into larger systems, larger organization. So how we negotiate at the political level, we negotiate by connecting value to say, how can we connect our values and principle with the one of public health? Now at the professional level, we say, okay, this is how we connect our values, but how do we connect our standards? How we work together to contain a pandemic? We need access to the population. We need autonomy and accountability to beneficiaries. We know that from humanitarian norms. But for the public health, the main point they want to see with humanitarian is to limit exposure to population. We want access, they want to limit exposure. So how are we going to find a way to get access while limiting exposure of the population? They want government control. It has to be organized by the government, and accountability not to beneficiary, but to public authority. And how are we going to find a solution? By building a consensus. And ultimately at the technical level, yes, we want to protect staff. We need equipment. We need resources. We need testing capabilities because we have a duty of care. We also need autonomy of resources. And in that sense, we need to work with public health positions and ministries and organizations. They want their own priority allocation. They want feasible program under the circumstances, and they want individual to take their responsibility to see how it's going to work. And in that sense, what humanitarian needs to do is to seek expertise, how to talk about their agenda, their methods, and their requirement in a vocabulary of public health to explain that's how we're going to operate, and we want to negotiate the details. So we'll essentially, this is what I had to present, to give an overview of the public health logic, definition, what is a pandemic, what is the R number, this famous number, and we see Cameroon is climbing up. There is a spreading and potentially exponential spreading of COVID-19 in Cameroon, and it will affect our capacity to work and to negotiate. And I hope it really opens some doors of reflection.